Hello, my name is Haley Traylor. This is my microbial disease presentation. This presentation will cover the diseases of the gastrointestinal tract, to include listeriosis, antibiotic-associated diarrhea, C. diff, and food poisoning. Again, this presentation is for basic microbiology for healthcare professionals at Utica University. To begin this presentation, I would like to review the anatomy of the digestive system to include the primary and accessory organs. The primary organs include the mouth, pharynx, esophagus, stomach, small intestine, large intestine, and rectum, whereas the accessory organs include the gallbladder, liver, and pancreas. Both of these images on the slide show the anatomy of the digestive system. They were both taken within the Body Worlds Museum in Berlin of real-life specimens. The gastrointestinal tract has very unique defense systems. It has a complex network of innate defenses to protect the host from commensal microorganisms versus pathogens. Commensal microorganisms are good, whereas pathogens are bad. The defenses of the GI tract include the stomach acid, which is very low, it's lower than 4, mucus formation of the gut, and gut motility, which is also known as peristalsis, flora, which is known as the gut microbiota, and mucin, as well as antimicrobial peptides. These all help to provide barriers and destroy pathogens. Here is a closer and more in-depth view of the digestive system mechanisms of protection, showing the barriers, acids in the stomach, and enzymes in the intestines that destroy the pathogens, the secretion of mucin and antimicrobial peptides in order to get rid of the pathogens and help the commensal organisms flourish. Gut microbiota, which is a very important of our gastrointestinal defense mechanisms. It is a part of our innate immune system. It hosts complex and dynamic populations of microorganisms. Microbiota influence the host during homeostasis and with disease invasion. Nutrition, such as probiotics and prebiotics, environmental exposures, and conditions of birth all affect our gut flora. Moving forward with the presentation, we'll begin with our first disease of the gastrointestinal tract, which is listeriosis, as can be seen in the image below, published by the CDC in 2022. A little bit of background on Listeria monocytogenes. They belong to the bacterial domain. The phylum is the Firmicutes, the class is Bacilli, and the family is the Listericidae. Moving forward with more background information on Listeria monocytogenes, they are gram-positive, meaning that they have a thick peptidoglycan layer and no outer lipid membrane. They are facilitative anaerobes, meaning that they utilize ATP by anaerobic respiration if oxygen is present, but they are capable of switching to fermentation in the absence of oxygen. They are rod-shaped bacterium, non-spore forming, and are found in moist environments. They are ambiguous, meaning that they are found in a wide range of places: humans, animals, soil, rotting foods, water, wherever you might find them, they're there. Acquired antibiotic resistance is rare. Usually, these cases are treatable with gram-positive targeted antibiotics such as penicillin, coccidiosin, and erythromycin. Cephalosporins and fluoroquinolones are not effective against Listeria. A significant clinical correlation is pregnancy. Infection from L. monocytogenes provokes sepsis, which is blood poisoning, meningitis, which is inflammation of the meninges, fetal infection, or spontaneous abortion in infected pregnant women. Those who are pregnant are 10 times more likely to contract a Listeria infection. Listeria can infect the placenta, amniotic fluid, and the baby. During the first trimester, miscarriage is at a high risk. As the pregnancy progresses, Listeria becomes more of a risk to the mother. It can lead to preterm birth, low infant birth weight, or infant death. Disease mechanisms of Listeria monocytogenes. Illness is caused by consuming contaminated foods or beverages. Pregnant mothers can also pass the bacteria to their unborn fetus. L. monocytogenes bacteria cross the epithelial barrier of the intestine. They translocate to the mesenteric lymph nodes and reach their primary target organs. Without T-cell mediated immune responses, infectious foci result in Listeria bacteria being released into the bloodstream, and invasive infection occurs. Entry and colonization of host tissues, meaning that they cross the intestinal border, multiply in the liver, colonize the uterus and fetus, and invade the brain. Clinical presentation of symptoms can vary, however, most common symptoms reported with listeriosis is headache, muscle pain, stomach pain, diarrhea, fevers, chills, and sweats, as well as nausea and vomiting. Diagnosis of listeriosis, clinical presentation, flu-like symptoms. For specific demographics, listeriosis should always be considered as a differential diagnosis. Within the elderly, neonates, immunocompromised, or pregnant women who present with flu-like symptoms, listeriosis should be considered and tested for. Infection is determined with bacterial cultures used to grow Listeria from bodily tissues, from the blood, spinal fluid, or placental fluid. In the lab, Listeria species will grow on nutrient Mueller-Hilton agar plates and conventional media incorporating sheep, horse, or rabbit blood. Lab cultures will result in gram-positive rods with beta-hemolytic colonies. To the right, we can see the colonies grown. The gram-positive rods are shown in purple, indicating gram-positive, and the beta-hemolytic colonies are shown, and the lysis of red blood cells does not go past the colonies. Epidemiology. In 1929, A. Nymphadite reported the first cases of listeriosis found in humans. Around 1,600 people contract listeriosis each year, which results in 260 Listeria-associated deaths in the United States alone. Pregnant women, newborns, the elderly, and those with a weakened immune system are at a higher risk of contracting severe cases of the infection. Pregnant women can pass Listeria to their unborn fetus. The main mode of Listeria transmission is orally, through the ingestion of contaminated foods and beverages. Symptoms can present between 3 and 70 days after consumption of contaminated foods. Listeria thrives in cool, moist environments. Most commonly, Listeria can be found in smoked seafood, soft cheeses, cold deli meats, unpasteurized milk, and unheated hot dogs. The most recent food safety alert Listeria outbreak per the CDC was posted on October 6, 2022. The outbreak was linked to Brie and Camembert cheese. This outbreak led to 6 confirmed illnesses and 5 hospitalizations. However, no deaths were reported. In 2017 and 2018, the world's largest and deadliest outbreak of listeriosis occurred in multiple provinces of South Africa. The outbreak was caused by the contaminated polony, a ready-to-eat processed meat product. This outbreak resulted in 216 deaths out of 1,060 confirmed cases. In this timeline, you can see multiple other current events of Listeria epidemic outbreaks. In 1985, there were 28 associated deaths with cheese products. In 1998 to 1999, 14 deaths were associated with hot dogs contaminated with Listeria. In 2002, 7 deaths were associated with turkey meat contaminated with Listeria, and in 2011, 33 deaths were associated with cantaloupes contaminated Listeria. Treatment and therapy strategies. Preventative measures include avoidance of commonly contaminated foods and proper hand washing techniques. Treatment strategies of listeriosis vary as there are different clinical presentations of the disease process. Most treatments revolve around a course of antibiotics. For gastroenteritis, which is also known as the stomach flu, only those who are immunocompromised or elderly are treated. Treatment includes oral antibiotics such as amoxicillin. For invasive disease processes as well as central nervous system infections, IV combinations of gentamicin and ampicillin are utilized. For those who are pregnant and neonates, IV antibiotic courses are utilized as well, with ampicillin without the use of gentamicin. Moving forward, we will begin to discuss antibiotic-associated diarrhea, or C. diff. A little bit of background information on C. diff. It belongs to the bacteria domain. The phylum is the Firmicutes. The class is the Clostridia. The family is the Clostridiaceae, and the species of C. diff is Clostridium difficile. Some more background information on C. diff. They are gram-positive, which again means that they have that thick peptidoglycan layer and no outer lipid membrane. It is a drumstick-shaped bacillus. It is spore-forming, which is very self-explanatory. It forms spores. It is an obligate anaerobe, meaning that it requires oxygen in abundance in order to survive. It can be found in water, air, human, and animal feces, as well as hospital surfaces and soil. This bacteria thrives at 98 degrees Fahrenheit, which is body temperature, and antibiotic use is the leading risk factor for C. diff infection. Penicillins, cephalosporins, fluoroquinolones, and clindamycins are all contributors to antibiotic resistance. As we can see to the right, this image shows the penetration factor of C. diff infections, hospital patients, or recent antibiotic use is the main factors for contracting C. diff, and it shows the process of infection, colonization. Disease mechanisms for C. diff. C. diff is highly contagious. It is transmitted from person to person within fecal matter or poop. This happens when people do not wash their hands after using the restroom or dealing with direct patient care that involves fecal matter. Exposure and ingestion occurs through the mouth and esophagus. In the intestines, bile exposure leads to germination of C. diff spores and transforms them into vegetative cells. Colonization and toxin projection occurs within the colon. Sporulation of C. difficile occurs within the colon. Two main mechanisms have been known for the action of toxin A and toxin B of C. diff, leading to the disruption of the cytoskeleton and tight junctions, and subsequent cell rounding, detachment, and cell death. C. diff risk factors include the overuse of antibiotics. This is one of the main risk factors, followed by recent hospitalization, being immunocompromised, being of advanced age, previous C. diff infections, and inflammatory bowel disease. These all heighten the risk of developing C. diff. Clinical presentation of patient symptoms. For those with C. diff, they will present with a loss of appetite, bloating, increased heart rate, fever, dehydration, weight loss, severe abdominal cramping and tenderness, blood in stool, kidney failure, and severe diarrhea, meaning 10 to 15 bowel movements per day. Granted, some patients may present with all of these, some may not, some may have a mixture. These are just the generalized symptoms. Diagnosis of C. diff. Symptomatic presentation. Stool samples are used to evaluate for the presence of C. difficile. Laboratory testing, however, cannot distinguish between asymptomatic colonization and symptomatic C. diff infection. Most labs only test diarrhea stool as well, and there are many different detection methods utilized to find the presence of C. diff in a stool sample. Colon examination is also utilized. Diagnostic video imaging procedures are used to identify areas of inflammation or abnormalities. A sigmoidoscopy is a lower part of the colon examination, or a colonoscopy, which examines the entire large intestine. Abdominal imaging such as X-ray and CT scans are also used as well. Epidemiology. C. diff is the most common healthcare-associated infection, and globally it is the most frequent hospital-acquired intestinal infection. C. diff was first isolated from the stool of an infant by Hall and O'Toole in 1935. C. diff infections and severity rates have increased within hospitals in North America and Europe since the early 2000s, secondary to an epidemic strain of C. diff, which is characterized by a higher toxin A and toxin B production, binary toxin, and high-level resistance to fluoroquine antibiotic resistance. In the United States each year, there are 453,000 cases and 29,000 deaths associated with C. diff. To the right, we can see this timeline with cases in the United States ranging from 2012 to 2017 of how many cases were associated with only hospitalized patients only contracting C. diff. They are all in the 200,000 range. Advanced treatment for C. diff is only necessary if a patient shows the signs or symptoms of infections. As previously mentioned, there can be asymptomatic or non-invasive forms of infection. C. diff is known to be resistant to multiple antibiotics such as aminoglycosides, linacalcimides, tetracyanides, erythromycin, clindamycin, penicillins, cephalosporins, and fluoroquinolones. Oral antibiotics, to include metronidazole, vancomycin, and fixadomycin, are utilized. IV antibiotics reach tissues faster in a higher concentration than oral antibiotics, but are used sparingly when treating C. diff infections. Another form of treatment would be FMT, which is fecal microbiota transplant. C. diff infections treated with FMT has an overall success rate of 92%, with 89% of patients responding after a single treatment. Surgical intervention is also utilized for severe cases by removing most of the colon and performing an ileostomy, which redirects the waste from the small intestine into a small waste bag. For recurrent infections, antibiotic-based therapy and probiotics are recommended as well. Okay, we have now reached our last section of food poisoning. Food poisoning does not refer to one specific pathogen. As we can see to the right, there are examples of multiple different pathogens that can lead to food poisoning. Some background information on food poisoning. Again, food poisoning is a broad term. It does not refer to one specific toxin. Food infections can be bacterial, viral, parasitic, or fungal in nature. The specific classification and taxonomy of food poisoning correlates to the specific foodborne pathogen that induced the food poisoning. A foodborne disease outbreak refers to greater than 2 cases of a similar illness resulting from the ingestion of a common food. The 5 most common foodborne pathogenic species in the U.S. are the norovirus, Salmonella, Colostrum perfringens, Campylobacter, and Staphylococcus aureus. Preventive measures. These measures help to prevent food poisoning. One must thoroughly wash their hands, maintain a clean workspace, prevent cross-contamination, maintain a clean cooking station, cook food thoroughly, follow use-by dates, and utilize proper food cooling techniques. In this image to the left, we can see the CDC dispensed these guidelines of washing your hands, separating different food groups, cooking food to the right temperature, and chilling appropriately, because all of these, if done incorrectly, can harbor bad bacteria to grow. Disease mechanisms. Food poisoning illnesses are caused by consuming contaminated food or beverages. The contaminated food passes through the stomach and allows for colonization to occur within the small and large intestines. Salmonella is a common source of food poisoning. After ingested tainted food with salmonella, bacteria invade the intestinal mucosa and proliferate. The bacteria can invade the lymph tissues and the gastrointestinal tract and then spread to the bloodstream. When proper preventative measures are not followed when preparing food or beverage, foodborne pathogenic spores are able to survive. Spore survival leads to germination, multiplication, and the production of toxins. Patients with food poisoning commonly present with fever, diarrhea, nausea and vomiting, abdominal pain, and abdominal cramping. Those with food poisoning also can present with urgent patient symptoms. With urgent symptoms, it is recommended that they seek medical attention immediately, such as blood and diarrheal stool, as well as diarrhea for more than 3 consecutive days, a high fever meaning one greater than 102 degrees Fahrenheit, and that is unresponsive to fever-reducing medication, such as Tylenol. Severe vomiting, which is preventing all oral and liquid consumption, as well as dehydration signs, to include dry mouth, minimal urination, vertigo or dizziness, and persistent severe diarrhea. Diagnosis of food poisoning. To diagnose food poisoning, one would need to obtain past medical history to include recent dietary and social history. With this information, a provider can understand if a patient ingested some sort of contaminated food or beverage, or if they were around someone who recently had contaminated some sort of food or beverage and is currently sick with food poisoning. Physical exam and symptomatic presentation. A provider would evaluate blood pressure and pulse because these are indicative of dehydration. They would also evaluate for abdominal pain, tenderness, as well as abnormal or absent bowel sounds. Stool tests are used to identify viruses, parasites, and bacteria. This is the primary method to confirm that food poisoning is occurring, and blood tests are used to identify infections, comorbidities, or complications. Epidemiology. Globally, foodborne illnesses are a significant health burden. They lead to high morbidity and mortality rates. In North and South America, we have the second lowest burden of foodborne illnesses globally. 77 million people fall ill, 9,000 deaths annually, and of those, 31 million are under the age of 5, resulting in more than 2,000 deaths. In America, 1 in 6 will fall ill secondary to a foodborne illness, resulting in 3,000 deaths. Worldwide, it is 1 in 10 that will fall ill and leading to 420,000 deaths. Norovirus, Campylobacter, E. coli, and non-typhoidal salmonella are responsible for causing 95% of food poisoning cases in the United States. Timeline of commonly known food poisoning pathogen. Salmonella is the most commonly known cause of hospitalization due to food poisoning in the United States. The global burden of salmonella has been estimated at 93.8 million infections of gastroenteritis, which is stomach flu as we previously learned, each year. This results in 155,000 deaths. Home remedies for food poisoning. Home remedies for food poisoning include the cessation of food consumption, which means stop food intake until the stomach has settled, the utilization of probiotics to prevent future food poisoning occurrences. Food poisoning definitely messes with the gut microbiome. It messes with the good and the bad bacteria within the stomach, so this helps to replenish the good bacteria and help protect the body against future foodborne illnesses. Rest is a given. Rest helps the body recover from what it has gone through after suffering from the foodborne illness, as well as a bland and easy to digest diet, such as the brat diet. The brat diet consists of bananas, rice, applesauce, and toast. It is bland and it allows for people who are nausea, vomiting, and diarrheal to consume some sort of dietary intake and nutrition while not upsetting their stomach even further. Medical intervention. Medical intervention for food poisoning consists of fluid replacement. This helps to combat the dehydration. Dehydration is one of the main symptoms with food poisoning. Antidiarrheal agents also helps with that fluid replacement, helps with the dehydration. Antibiotics are used sparingly. They are used for bacterial and parasitic infection only, and when antibiotics are used for food poisoning cases, they are used in the form of macronide antibiotics and fluoroquinolone antibiotics. All other antibiotics will not work and they are not active against food poisoning cases. Okay, thank you for watching. We have now reached the end of the presentation. This last slide shows all of the references utilized.